Oh, hello. Were you there this whole time? Well, since you're here, would you like to join me for some hormones? They're very interesting. Here, it's all in the box. Take a look for yourself. Oh. What are hormones? When you talk about hormones, you may immediately think of sex hormones, like estrogen or testosterone. And you're right, they are definitely hormones. But they're not the only ones. There are over 50 different known types of hormones in the human body, with more surely to be discovered. The word hormone comes from the Greek word hormeo, a word that means I excite or arouse. What is meant by this is that hormones send signals from parts of your body to other parts in order to cause them to do something or change in some way. As an example, the feeling of being hungry is partially caused by a hormone released by your stomach. It travels through your bloodstream and signals to the rest of your body that you should feel hungry. There are many more hormones that do a lot of different things, but they all work in generally the same way. On the cells in your body, there are these things called receptors. Receptors are basically like locks that are waiting for the right key that can open them. When that key shows up, it activates the lock and your cell does something because of that. Hormones in this example are the keys. When the right hormones are together with the right cell receptors, it causes a change to happen in the cell. Not all cells have the same receptors, so some hormones may not do anything to some cells but may do something to others. Also, even if a cell does have a receptor for a hormone, what that cell does when that hormone activates it is different depending on what type of cell it is. There's a lot more to it than that, of course, and I highly recommend reading more about it. It's very interesting. But for the purpose of this video, that's generally all you need to know. Hormones tell your body to do stuff. Now that you know what a hormone is, let's talk about sex hormones. Sex hormones are also called sex steroids, or sometimes even just steroids. You probably know some sex hormones already, like testosterone and estrogen. They're both types of sex hormones. There are certain receptors on the cell called androgen receptors and estrogen receptors. And these are the receptors that sex hormones activate. Testosterone is a type of androgen, which is why it activates androgen receptors, and estrogen, of course, activates estrogen receptors. While sex hormones are responsible for a variety of things in your body, we'll be focusing on the way they change the development and expression of sexual characteristics, motivations, and psychology, especially in regard to male to female transgender females and their hormone replacement therapy. I'll be referring to things as being male or female in regards to cisgender XX, XY humans unless otherwise stated. It's simply easier to talk about this way. First, we'll go into the major sex hormones, testosterone, estrogen, and some others. Then we'll talk about how hormone replacement therapy works for male to female transgender females. Testosterone is commonly thought of as the male hormone. However, it is present in both males and females, though the levels present in males are significantly higher. Testosterone's role in males is more pronounced. It is responsible for the development of male reproductive tissues such as the testes and prostate, as well as male sexual characteristics such as body hair, facial hair, and increased potential to gain muscle mass. Testosterone is also critical for male sexual function, including the development and functionality of sex organs and male sexual motivation. The elimination of testosterone in males has been shown to reduce sexual motivation. While females do have natural levels of testosterone, it is significantly less than in males. The purpose of testosterone in females is not well understood. Some have thought that testosterone could be responsible for sexual desire in females. However, research has not proven this to be the case. While there has been research that has shown that if females are given enough testosterone to have more than they naturally would, they do begin to have higher sex drives. No such research has found this to be the case when women are only given testosterone to be within the normal female range. There's been some interesting research that found that polyamorous females and males had higher levels of testosterone than non-polyamorous people, with the levels in women being nearly as high as the lower levels of natural male testosterone range, though it's not well understood why this is the case. Overall, there is a lack of high-quality, consistent evidence that testosterone affects female sexual desire, unless it is higher than the typical natural female range. Testosterone also has effects on the brain. Androgens like testosterone are considered to be responsible for men having greater visuospatial ability. For instance, being able to accurately rotate objects in your mind or estimating the distance between two objects is visual spatial ability. However, testosterone is also considered to lower verbal fluency in males. For instance, females are generally better able to find words for categories of things such as types of animals, words that start with the letter A, and that sort of thing. In animals, higher levels of testosterone are well known to increase aggressiveness, especially when attempting to mate. In human males, the role of testosterone in aggressiveness is controversial. There's a significant but not strong relation between testosterone levels and some aspects of aggressive behavior in men. Anabolic steroid users, which are, for example, weightlifters who use steroids such as testosterone in order to increase their muscle mass, significantly report mood disorders, manic states of high aggressive energy, as well as various other psychiatric disorders. There have also been findings that administering high doses of testosterone to men is associated with increased aggressiveness compared to a placebo group. There have also been studies that were not able to find clear increases in aggressive behaviors in men treated with testosterone. So it should be noted that this is still an area of moderate uncertainty. Estrogen is the primary female sex hormone, and it is responsible for the development and regulation of the female reproductive system as well as the development of female secondary characteristics, such as the growth of breasts. Though estrogen levels are higher in females, estrogen is present in males as well, and it has been found to be important to male fertility by regulating processes necessary for the development of viable sperm. Though, it should be noted that evidence also suggests that exposure to too much estrogen in males does inhibit fertility. Estrogen typically regulates motivation to engage in sexual reproduction in female mammals. Though, unlike males, the relationship between hormones and female sexual motivation is not well understood. Primates such as monkeys and humans are some of the only animals who mate outside their fertile period. However, female primates are able to mate at any time. Research also suggests that the desire to seek out sex in female primates is higher during the periods when they are fertile as well as during pregnancy, both of which are times when female hormones are at their highest levels. Also, during menopause, when a female is no longer fertile and thus produces much less estrogen, many women experience a decline in sexual motivation. Menopause causes the hormones in females to be lowered drastically. A majority of women experience some change in sexual function due to menopause. Common complaints include a loss of sexual desire as well as a decrease in physical response and pleasure. Studies have found that it's possible to modestly restore the sexual state of menopausal women to premenopausal levels through the administration of estrogen treatments. There's more to sexual arousal and pleasure in humans than just hormones. The psychological state of the individual or the social context they're in are both important factors. However, the role of hormones in human sexuality appears to be undeniably significant. In the brain, estrogen may have a role in sustaining cognition in old age. Many women experience changes in cognition when estrogen levels are lowered through menopause or surgically induced menopause, such as the removal of the ovaries. Progesterone is the other main sex hormone in females. It's primarily involved in the regulation of the female reproductive system, the menstrual cycle, pregnancy, and lactation. Outside of its role in pregnancy and lactation, progesterone seems to be mostly insignificant in the development of female sex characteristics. During puberty, progesterone levels do not rise significantly until the end of puberty after most development has taken place. While progesterone does prime the body for pregnancy and lactation, these changes are only temporary by design and disappear when progesterone levels are lowered. In addition, no research has found progesterone to improve female sex drives. Now you should have a decent idea of the major sex hormones testosterone, estrogen, and progesterone. While there are other sex hormones, these are the ones that will be the most important to understand for our next topic. So, what is hormone replacement therapy? Maybe you already know, but there's no harm in being clear. Hormone replacement therapy, also called HRT, is the administration of medicine and medical services in order to change the hormonal levels of a person from one sex to another. For instance, in male to female HRT, Medicine is used to raise a person's estrogen levels and reduce their testosterone levels. In female to male HRT, the goal is reversed, and medicine is used to raise testosterone levels instead. The effects this has on a person vary depending on many factors such as age and genetics. There are limits to what HRT can and cannot do. We'll only be focusing on male to female HRT from here. Female to male HRT deserves its own video. For male to female transsexuals, HRT can possibly develop the breasts, reduce male sex drive, make skin softer, stall or stop hair loss, change how body fat is distributed, reduce muscle mass. In puberty, it can cause the body to grow on a feminine path, and it can also stop further masculinization from puberty. These changes can generally be expected to happen on the following timeline. Within 1 to 6 months, body fat will redistribute to be more like female fat distributions, and muscle mass will decrease along with overall strength. Also during this time, skin will become softer, sex drive will decrease, erections may become impossible to obtain, and orgasms may be difficult to achieve. In addition, the ability to produce sperm will be lost, and as a result, infertility will occur. Within 3 to 6 months, tender breast buds may start to form, and gradual breast growth and nipple development will possibly continue for 2 or more years, though the degree to which the breasts will develop varies greatly from person to person. Over several years, face and body hair will become finer and will grow slower, though facial hair will change much less than body hair. HRT may gradually slow or even stop male pattern baldness, however it will not regrow hair that has already been lost. Most of these changes are reversible if HRT is stopped. However, breast development is permanent, and it's possible that the ability to produce sperm and fertility may not return. Sperm banking is recommended for all male to female trans females before beginning HRT, as it is very likely it will be impossible to ever have children otherwise. However, there are many things HRT cannot do, such as significantly grow back hair lost due to baldness, reduce the size of shoulders, hands, height, etc., cause the voice to become higher, significantly reduce facial hair growth, reduce the size of the Adam's apple, or undo changes from puberty. Also, it will not allow for female reproduction. As you can see, there is a lot HRT can do, but it can't do everything. We're going to get a bit more in-depth about the changes that can be expected from HRT. Then after that, we're going to discuss what medicines are used for HRT and how they work. Breast development is one of the most noticeable changes from HRT. Within 3 to 6 months of starting HRT, breast buds may start to form. The breast and nipples will gradually continue to develop for anywhere between 2 years and a decade. In thin M/F females, weight increase may improve breast development. Typical male to female breast development is not as pronounced as it is in females, and many male to female females choose to have breast augmentation. It is recommended to allow 18 to 24 months after starting hormones before considering breast augmentation. The width of the shoulders and the size of the rib cage affect how large a person's breasts appear to be. And because these both tend to be larger in transgender females, many choose larger implants than those typically chosen by cisgender females. Under the right circumstances, it is possible for the breast development of M/F females to allow for lactation and even breastfeeding. The method used to do this is the same as some adoptive females use to be able to breastfeed an adopted infant, and generally requires a hormone regimen to be able to achieve pregnancy hormone levels in estrogen, progesterone, as well as prolactin, a hormone required for lactation. In addition, frequent breast stimulation is required, typically using a breast pump. All of this is rather demanding on the body and requires medications that are not well studied, so it is recommended to only attempt to lactate for the purposes of breastfeeding a child and with the assistance and approval of a doctor. HRT has some effect on the skin, though these changes are reversible if HRT is stopped. Collagen in the skin decreases and the skin becomes thinner, softer, and more transparent. Tactile sensation increases as well, and skin becomes easier to tear and irritate. Oil production on the skin and scalp will be reduced due to the lack of androgens, and as a result, pores may become smaller and skin may become less prone to acne, though at the cost of it becoming drier as well. Subcutaneous fat, the fat immediately underneath the skin, increases due to HRT. As a result, cellulite and stretch marks may become more visible. Hair on the head, face, and body are affected by HRT in different ways. Head hair may change slightly in texture, color, or curl, partially due to a loss of oil production on the scalp. If balding has already begun, the hair that has been lost already will generally not be restored to a pre-balding state, though further hair loss may be prevented. Facial hair is only minimally affected by HRT, and it's unlikely a significant reduction in the growth of already present facial hair will result from HRT. Though, if HRT is begun in puberty, it will prevent further hair development. Facial hair will almost always need to be removed through other means, such as laser hair removal and electrolysis. Body hair can see a more significant change, and it is common to have reductions in body hair present on the legs, thighs, chest, back, and stomach and arms. However, this is partially determined by genetics, and the degree to which body hair is changed varies from person to person. It is common for cisgender females to have body hair as well. The distribution of fat in the body slowly changes over months and years during HRT. Fat tends to accumulate more in feminine areas such as the hips, thighs, buttocks, pubis, upper arms, and breasts. In addition, fat in more masculine distributions such as the waist, shoulders, and back may begin to reduce. Subcutaneous fat, fat under the skin, increases in the cheeks and lips, which may make the face appear rounder, and it may de-emphasize some masculine aspects of the jaw. Muscle mass may tend to decrease towards female proportions due to the elimination of androgens following HRT. New muscle also becomes harder to gain. Bone changes that have already occurred are not reversible by HRT, though it is possible for them to be prevented if some form of HRT or androgen blockers are initiated at a very early age. The majority of changes to the bone structure of the face occur early in adolescence, and changes to the skeleton such as the length of the arms and legs, the size of the hands and feet, the broadening of the shoulders and the rib cage, and total height are mostly complete by the end of puberty. However, some bones are not finished developing until around the age of 25, and HRT can affect some change in bone growth if it has started before then. And this may result in some degree of feminization such as wider hips and feminine development of the interior of the pelvis. After the age of 25, most of the bones in the body will have permanently fused, and HRT will no longer have an effect on the structure of the skeleton. Because most of the bone structure development in the face has already occurred by the time many trans women are able to begin HRT, it's common for MTF females to consider facial feminization surgery. Also called FFS, facial feminization surgery involves a variety of surgical changes to the face in order to achieve a more typically feminine appearance, including but not limited to removing masculinized bone structure in the face. In addition, while not part of the skeleton, the thyroid cartilage, also known as the Adam's apple, may be removed as part of FFS, or separately on its own, as thyroid cartilage cannot be reduced through HRT either. The voice cannot be changed through HRT. However, if administered before changes have occurred, further changes to the voice can be prevented. If the voice that is satisfactory for the MTF female cannot be achieved through practice, it is possible to have voice feminization surgery to raise the range of the voice toward more typically feminine levels. Sex drives following HRT are generally reported to be lowered. Spontaneous erections are reduced in frequency, and erections may be impossible to achieve at all, though this varies from person to person. The reduction in sex drive is often one of the first changes many trans females notice when they begin HRT. Following sexual reassignment surgery or an orchiectomy, the removal of the testicles, the testosterone levels of a trans female are often lower than the testosterone levels of a cisgender female, and some trans females take testosterone in order to improve their sex drives. However, studies have been unable to show that testosterone has an effect on females when administered below male levels, and research in regards to female levels of testosterone present in trans females and its relation to their sex drive is practically non-existent. Fertility, the ability to have children, is almost certainly lost at some point after initiating HRT. The production of viable sperm is disrupted directly. Though it may be possible for fertility to be regained if HRT is stopped and no surgeries have been performed, it is not guaranteed, and many will permanently lose their fertility. As such, it's important to assume that it will be impossible to remain fertile once HRT is begun, and it's likely a good idea to consider using a sperm bank to preserve sperm in the event that children are ever desired. The medications used in male-to-female hormone replacement therapy have changed over time, and it's very possible that they will continue to change in the future. Currently, HRT regimens typically consist of an estrogen, an androgen inhibitor, and sometimes a progestin. Regardless of what medicine is used, the goal is generally the same: to raise estrogen levels to within female range and to reduce testosterone levels to below male range. We'll talk about the current medications used in male-to-female hormone replacement therapy, and while this information is in line with current clinical guidelines, it is always preferable to have a doctor determine the current regimen for each person and to monitor them throughout their transition. Estrogen is the primary hormone in females, and as such is also the primary hormone in HRT. There are a variety of available forms of estrogen as well as methods of administration. In the past, a type of estrogen typically found in birth control pills called ethinyl estradiol was used. However, it is strongly recommended not to use this medication anymore, as it poses significant health risks, and there are much better alternatives. While no estrogen therapy is completely without side effects, transdermal estradiol has been shown to have reduced side effects compared to oral estradiol. Between patches and injections, patches offer the most convenience and maintain steadier estrogen than injections. Some trans women believe that injections offer better feminization, and while some evidence has suggested that injections may possibly cause feminization to occur faster, in the end, the final degree of feminization achieved through HRT seems to be the same regardless of the method in which estrogen is administered. The type of estrogen used in HRT is mostly well agreed to be forms of estradiol, which is the most potent naturally occurring estrogen in the body. The estrogen in patches and pills is currently recommended to be estradiol, and in injections it is recommended to use estradiol valerate, which is converted into estradiol in the body. While results are typically the main focus of male-to-female females seeking HRT, it is also important to take health into consideration as well, as it is possible to optimize for both results and health at the same time. Androgen blockers, or anti-androgens as they're also known, are medications used to reduce the levels and/or action of testosterone and promote estrogen levels. Typically, some form of anti-androgen is included in male-to-female hormone regimen. However, recent research suggests that in many cases, an estrogen-only therapy is able to achieve testosterone suppression on its own as well. The necessity of anti-androgens and the type of anti-androgen therapy necessary varies from person to person, and hormone levels will require monitoring with the assistance of a medical professional in order to ensure that levels are within female range. There's a variety of medications used for their anti-androgenic effects in male-to-female HRT, and it's worth discussing the ones that are most currently commonly administered at this time, regardless of if they are currently recommended or not. Spironolactone is one of the most commonly prescribed anti-androgens at this time, especially in the United States. Spironolactone works by blocking testosterone from being able to bind to androgen receptors on the cells. It does this by taking up the space on the receptor that testosterone needs to bind to, which makes testosterone unable to bind to it. Current research has put some aspects of spironolactone into question. While spironolactone is able to block testosterone from activating cell receptors, it does not seem to reduce testosterone production. And in addition, it may make it harder for estrogen to reach desired female levels. Spironolactone use is not intended to be continued forever. Eventually, most MTFs on HRT are suggested to have some form of testicular removal. That way, testosterone production will cease and all anti-androgens will no longer be needed. Despite all this, spironolactone may still be a part of HRT regimens for many transgender females. Ultimately, treatment is a highly individualized process and requires working together with medical professionals to find the best solution for each person. Gonadotropin-releasing hormone modulators, also called GnRH modulators, work by eliminating GnRH production. GnRH is responsible for the release of two hormones, follicle-stimulating hormone and luteinizing hormone, which are hormones responsible for controlling sex hormone levels in the body. Because GnRH modulators eliminate the production of GnRH, FSH and LH are also eliminated, which means sex hormones are no longer produced. GnRH modulators are very effective and they have fewer side effects than other current anti-androgen therapies. However, despite the benefits offered by GnRH modulators in HRT, many health insurance providers do not currently cover them. It's possible that in time, more transgender therapies will include GnRH modulators, and currently, GnRH modulators are regularly administered to transgender youth in order to safely delay puberty. Bicalutamide is another anti-androgen that works by blocking testosterone's ability to bind to androgen receptors. If GnRH modulators are not covered for an individual requiring an androgen blocker, bicalutamide could prove to be a promising alternative to spironolactone. Medroxyprogesterone acetate is a synthetic form of progesterone which is sometimes used as an anti-androgen. Medroxyprogesterone works by lowering the production of GnRH. However, it is much less effective than GnRH modulators at doing so. In addition, medroxyprogesterone is suspected to increase the risk of breast cancer and increase the risk of cardiovascular complications. Many other anti-androgen therapies are available which are potentially safer than medroxyprogesterone, while being potentially more effective as well. Cyproterone acetate is another type of synthetic progesterone, like medroxyprogesterone. Cyproterone has about the same effectiveness as medroxyprogesterone, as well as similar side effects and downsides. FINASTERIDE is a medication that is rarely prescribed to transgender females for HRT. FINASTERIDE is generally used to prevent male pattern baldness, and it does so by preventing testosterone from converting into another type of hormone called dihydrotestosterone. However, FINASTERIDE does not prevent the production or effects of testosterone itself. And because other anti-androgen therapies already suppress the effects of testosterone, it's very unlikely that FINASTERIDE will provide any benefit in male to female HRT, and may in fact cause other problems as it has been linked to side effects such as depression and anxiety. Progesterone is the secondary female sex hormone, and its use is mainly to prepare the body for pregnancy and lactation throughout each menstrual cycle in women. Progestins are synthetic forms of progesterone that, to varying degrees, mimic its effects. Occasionally, progesterone and progestins are used in male to female HRT for their anti-androgenic properties. It is a common belief among male to female transgender females that progesterone or progestins are responsible for permanent feminizing effects, such as breast development or nipple enlargement. However, current research does not agree with these claims. In females during puberty, progesterone is not present at significant levels during the majority of bodily feminization and development, with levels only increasing towards the end of puberty after the majority of feminization has already occurred. Studies have also looked at people who have a condition known as complete androgen insensitivity syndrome, a condition which causes genetically male individuals to be immune to the effects of testosterone since birth. Because of this, their bodies mostly develop as if they were genetically female, because human bodies are initially female in the womb until they are masculinized by androgens such as testosterone. In these individuals, their bodies produce no natural progesterone. However, they do produce a small but significant amount of estrogen. Interestingly enough, During puberty, these people experience full breast development and often have even more development than average. This suggests that there is no significant role for progesterone in the development of permanent breast tissue, and it even might reduce overall breast development. Additionally, synthetic progestins have been linked to increased chance of breast cancer. Some individuals mistake the side effect of progesterone, increasing water retention, to be breast development. However, this is actually just the body retaining more fluid, a temporary effect that is not actually helping to develop breast tissue, and which actually causes potential complications such as venous varicosis. While progesterone is responsible for changes in the breast during pregnancy and lactation, these changes are temporary and will go away very quickly if progesterone use is not continued. I collected this information to the best of my ability, and I've reached out to medical professionals to help validate the research I presented. All of this is subject to change, as medicine is a constantly evolving field. I'll be making revised versions of this video in the future to cover new information as it's made available. Oh, you're still here! That's great! Sorry about breakfast though, I kind of already ate everything. But you should come back. Next time I'll have something really nice for you. But before you go, there's something I should show you. These cool people donated to my Patreon, which is the only way I'm able to do awesome stuff like this. If you'd like to support me, donating to me on Patreon could literally change my life, and you might get your name on the next box, metaphorically. There might not be a next box in the next video. Unless you really like boxes, let me know if you really like boxes. Also, I'm obligated by internet law to ask you to subscribe and press that bell. If I don't do that, I might go to internet jail, so please do it for me. Thank you so much for watching. Bye!